So I need to make some disclaimers. First, I would like to acknowledge the traditional custodians of my land, the Australia, and pay respect to the past, present, and the emerging, and also thank my patients and my hospital colleagues who have made this possible for me to be here. And in terms of the Parkinson's or movement disorder, we talk quite a bit about the motor symptoms and the movement disorder clinics. That's very well established across the globe. There is quite an emerging interest in the non-motor symptoms. So what I'll be talking today is about our practical experience in the unit that we have developed as an integrated movement assessment program, which is one of its kind in the globe, which was one of my brainchild in collaboration with my allied health clinicians who made it possible. So it is more of an assessment process pathway where we do an integrated assessment with my allied health clinicians. We spend about 3 hours with the patient. And then we like a triage and traffic in terms of to decide where the patients can actually go from there in terms of the medical management, physical, functional, psychosocial, and other community services. Essentially, the goal is to minimize unnecessary healthcare utilization across the district. And B is that the patients find it is a value-added care because they tend to wait for seeing the neurologist for 9 to 12 months. And the primary healthcare physicians are pretty much not comfortable managing the non-motor symptoms along with tweaking the Parkinson's medication. So essentially, we did a business case study for about 12 months before we rolled out this program. So what I'm talking about today is not rocket science. It's not all your very high-end orthopedic big things we're talking about. This is about the human experience, about the patients, and what are we experiencing on a day-to-day basis with these movement disorder patients and how we can effectively manage. Management of these non-motor symptoms are pretty much, we may do it as a primary healthcare physicians or doctors, but it is mainly the identification and the neurological pathways that's involved. So it's more to raise the awareness. So that's a bit of a brief about this talk. I've packed a lot of information, so I might, given the time, might go a little bit quicker, but we can have the questions at the end. So if someone can time me for about 40 minutes, if that's okay, please. Yep. Yeah, thank you. So non-motor symptoms. So non-motor symptoms, I classify them as somatic, cognitive, neurobehavioral, autonomic, and sleep dysfunctions. They are considered the non-motor symptoms. The cardinal symptoms of Parkinson's disease, as you probably know, is tremor, rigidity, bradykinesia, and postural instability. As an idiopathic Parkinson's disease, these are the hallmark 4 signs that you need to have. But we all know that Parkinson's disease comes under the various forms. You can have vascular Parkinson's disease, which is more with the subcortical chronic ischemic, chronic small vessel ischemic burden, which is very underlooked and underdiagnosed, and they don't respond very well to Parkinson's medication. So vascular Parkinson's, you've got unilateral upper body Parkinson's, you've got a unilateral lower body Parkinson's, you've got bilateral lower limb Parkinson's. So they could be so subcategorized dyskinetic syndromes. So they're all part of it. But what is one thing in common is the non-motor symptoms. So all of these subgroups of Parkinson's disease can have the non-motor symptoms. So let's talk about why and what happens. So to go back to the pathology of it, so anatomy and pathology of it, so to just quickly run through that. The non-dopaminergic process is the key to the non-motor symptoms, which is very interesting because you might think that the dopamine is predominantly involved with the Parkinson's motor symptoms, but then your non-dopaminergic pathways are very key in this. And there is a significant loss, especially with the vagus nerve. Why vagus nerve? No idea. I don't know. But that's the way it is. And it's very interesting to see that vagus nerve is which only cranial nerve, which takes its origin in the brain and goes up to your gut and supply your heart. None of your cranial nerves, all the cranial nerves are in your face, but your vagus nerve, this is for the general population, I tend to say this, and not particularly doctors, but so the cranial nerve 10 has got a very unique role in your system. It controls your breathing, it controls your autonomic system. That's why you get a butterfly effect in your stomach when you're not comfortable. It's all vagus. It does it. So the vagus nerve seems to be quite intricately associated and linked with the substantia nigra network. And you find that the cholinergic pedunculopontine, which is the cerebellar nucleus, and the midbrain neurons, and the substance P, there's quite a bit of loss in the substance P. So what does it tell you? So these patients tend to get an increased central sensitization of pain. There is also increased peripheral sensitization of pain, and your vagus nerve is altered way, way ahead of your Parkinson's symptoms. And you will find that this black area, which I took a picture of from the anatomy book, seems to be way involved prior to any Parkinson's, you can say up to 10 years ahead. So patients can have up to 7 to 10 years ahead of non-motor symptoms, and then you follow through them, and then they'll end up having Parkinson's disease at some stage. And this is, I'm going to quickly go through this. This is all theoretical mumbo jumbo, but we do have a medullary dopaminergic pathway is completely spared. Your non-catecholamine neurons severely depleted, which then explains why these patients end up having postural hypotension, which is very central. So you can do whatever it is, but it's a very centrally mediated postural hypotension effects. And then you've got a lot of vasoactive intestinal peptide neurons that are affected in the entering nervous system, which results in a significant hypomotility syndrome in the gut. So constipation is way, way high up. It starts 7, 10 years ahead of Parkinson's disease. So we can classify them into a preclinical phase with the positive biological markers, although we don't do it. It's all in the research arena at the moment, but not clinically sort of rolled out yet. I went to the movement disorder conference last year in Denmark, and a lot of companies are coming up with these alpha-synuclein pathway skin test biomarkers they're coming up with, and then pre-motor phase, and then you've got a motor phase. So it's being... So these, in the last 2 years in our integrated assessment clinic, we found these are all the symptoms that I see practically what's happening here. So we've got hyposmia, anosmia. You've got sleep disorders, especially the rapid eye movement sleep in the early morning. They tend to have vivid dreams. And quite interestingly, if patients put on Cifrol, which is pramipexole, one of the dopaminergic medication, that seems to augment the rapid eye movement disorder sleep issues. And then you've got constipation, which is way up. Depression, again, depression is a very unique thing, but I'll talk to when I come to that. And then fatigue, significant central fatigue, pain, erectile dysfunction. So we do have a lot of biological markers from gastric biopsy, phosphorylated alpha-synuclein positive fluid, nitrites, uric acid, low-density lipoprotein, serum cholesterol. So these are all being rolled out, looked at it. But the most importantly, the skin biopsy alpha-synuclein accumulation has been taken a significant interest. I think in about 3 to 5 years, that will be rolled out as a very precursor test in the market for Parkinson's. I won't go into this one. Now, if you are a clinician, you can grade them using this King's classification. And we can sort of go into the net and identify what are the grading mechanism. I tend to use this in my clinic as part of the severity of the non-motor symptoms. So if you have, can be classified into mild, moderate, and severe, or very severe. Okay, so let's go back to this symptom management or disability management, because as a rehab physicians or a physiatrist in America or anyway, we are more interested in the what the impairments Then, of course, the ICF has changed the definition of the disability into activity limitations now and participation restriction for disability, because you can't name a patient, call a patient disabled anymore. So drooling. We all know Parkinson's patients have a lot of drooling. So what happens here? Pathology is there is a dyskinetic movements within the oropharyngeal pathway, results in squeezing of the glands. But it's not a manifestation, it's more a manifestation of akinesia and of course the management. As I said, it's more identification and why happens rather than the management. We all know that cholinergics will work. Glycopyrrolate, I tend to use glycopyrrolate 2 milligrams to start with. And secondly, I use an atropine drop, 1 drop. You can use it every 4 hours under the tongue. That seems to work for drooling. Then the third step, for 3 months, if it doesn't work, I inject botulinum toxin into the parotid gland and submandibular. So you can actually inject about 25 units. That seems to work. You don't need a big units. 25 units should work very well. This is a significant dysfunction for the patients, especially, and it predates the Parkinson's. Of course, there are other causes for anosmia, where patients, if they're a chronic smoker or chronic sinusitis, they can have this. But olfactory bulb degeneration and the anterior olfactory nucleus degeneration is considered to be one of the precursor for Parkinson's disease. Can affect up to 90% of the patients. So it's mainly compensation to manage them, because you really cannot treat them by any other means. Swallowing issues, dysphagia, the dysfunction in the oropharyngeal faces. Again, this is more secondary to the dyskinetic movements of the oropharyngeal pathway rather than central. And there is a poor activation of the tongue and cheek muscle control, discoordination. Anyone from if the patient has got dysphagia or choking, what would be your preferred medication for these patients? I know Subramaniam manages patients all the time. So anyone? Medication specifically? Yeah. For dysphagia? Yeah. Well, basically, because of the coordination seems to be the major problem here. So it's more like you would have heard about the bladder sphincter dyssynergia. It's exactly the same. So if the gastroesophageal junction will be quite tight, the esophagus will keep on moving. And then when the valve opens, then it stops. So essentially the food gets stuck. So you tend to use mutilium. Now, you don't use Maxilone or other Zofran or other antiemetic medications, as you probably know that they can aggravate your extrapyramidal symptoms. So in my practical experience, mutilium seems to work wonders with these patients. So you give 10 milligrams 3 times a day and it actually, the other advantage of the mutilium is it augments the effects of the levodopa as well. So it works perfect for these medications. You just do 20 minutes before, 3 times a day before the meal, it works. So the dysphagia is effectively managed clinically, not by just the speech therapy, but especially with the medications, you can help them. Nausea and vomiting can be related to the effects of dopamine medications. Again, it's a very bread and butter management for all the clinicians. Constipation, very, very difficult to treat because of the hypomotility. There is an increased gastric time. So the current study shows that there's a lot of toxins there is a gut-brain axis involved in Parkinson's disease. So because of the accumulation of the toxins, they actually gets reabsorbed into the enterohepatic circulation. That gets absorbed into your brain structures, and that's why patients with Parkinson's has a kind of a uremic encephalopathy because of the accumulation of the toxins. So it is very important. And there's a dysautonomia because you probably know that the gut is supplied by a nervous system called mucinous plexus, and they've got the mind on their own. That's why we call bowel training program. You can't just, and they've got a significant latency effect. you can't actually train your bowel in 1 day, 2 days, 3 days. No. It is a pattern-based learning because they are unmyelinated C fibers, unmyelinated nervous system. They go with behavior associated with pattern-based learning. And that's very much controlled by the mucinous plexus, which is then has got a control through your spinal cord and the brain. So that's why if you want to train your bowel, it takes time, but they get trained properly. But it is very conditioning effect as compared to your other movements in your body. So in spinal injuries or brain injuries, that's what we call as a bowel training program. It takes time. You have to train the bowel because that nervous system is very autonomous, as you might think. It doesn't listen to you all the time. We all know how to manage constipation, so I'm not going to tell you guys what to do. So be sensible, water, fiber, exercise, exercise, exercise. That's the only thing that helps with the constipation. Yeah. Bladder dysfunction. So similar to what I told you about the gastroesophageal, the same principle applies here. So there is the most thing that I see in my clinic is the detrusor hyperactivity or overreactivity. What happens is, you all know that when the urine enters into the bladder, the first 100 mils, there is an impulse that's sent to the brain through the spinal cord if you want to pass urine. Now, the frontal lobe, which is involved in controlling that as a social situation, saying that, no, I don't want to do it now. It's okay. Then the bladder fills up to 300 to 400 mils. You get the second signal through the sacral plexus. It goes to the brain. Then the frontal lobe will decide if I want to evacuate or I don't want to evacuate, depending upon the social situation. About 600, 700 mils, it'll say go. Now, depending upon the bladder compliance, the balloon, the valve will coordinate. And remember, you talked about the beta blocker. Good point there, because the balloon is different. The receptors are different to the bladder, the valve. So the valve is more alpha, the balloon is beta. The receptors, they're all coming under the receptors. So with the detrusor hyperactivity, what happens? The balloon keeps on irritating when the urine comes, even with 100 mils, but the sphincter will open. So Parkinson's patients will wake up 3 to 4 times at night time, going to the toilet, and they'll have just 2 drops, 3 drops, or less than 100 mils. That's it. So their sleep is affected because of this hyperactivity. This is exactly the same we tend to see in stroke patients, brain injury patients, sometimes in spinal injury, higher spinal injury patients, is because the spinal cord will take over the management of the bladder and the brain will actually stop. So it's the reflex mechanism of the spinal cord will try and empty it, try and empty it, try and empty it. That's the problem. You can get other issues with the urinary retention or atonic bladder, but that's very rare. In my clinical experience, bladder dysfunction is due to the hyperactivity, and the mechanism that has been shown is here is the bladder neurons have been degenerated, and that is actually represented in your substantia nigra, which inhibits the urination that also leads to bladder dysfunction. That's why these patients are very classically will present with bladder hyperactivity. So the best way to manage them is, of course, you can do timed voiding, but it's very difficult at night time. Of course, once you put them on the dopamine therapy, it tends to get better, but no, non-motor symptoms, invariably, I do put them on bladder relaxant, as what I call. You can use oxybutynin, you can use Vesicare or sulfonacin. There are other medications that's on board that's come on market. If I really have trouble, then I refer them to the urologist, because I don't do botulinum toxin on the bladder wall. I refer them to the urologist if it's a very severe problem, but we have done that. Pain. Now, pain, we all know, is a significant disability. It's not an impairment. Pain is a disability by classification. So it limits your activity and it inhibits your, it makes you more handicapped. Can be a primary pain, can be a secondary. And these patients have got decreased pain thresholds, as I discussed before, due to the alteration and degeneration of the dopamine receptors. And there is also the norepinephrine degeneration in the locus coeruleus nucleus. And the substance P upregulation results in increased pain perception of these patients. Very interestingly, pain with the movement disorder in my clinic, I ask the standard question, where is your pain? Where do you get this pain? They talk about, I've got this lower back pain, persistent lower back pain in this regional, and sometimes it goes to the glutes, and sometimes it's like a sciatic pain, very commonly used as sciatic, which is a misnomer. I don't use sciatic, but it's a very misnomer. So they tend to have quite a significant lower back spinal rigidity, paravertebral spinal rigidity. And also they tend to have, due to the tightening of the piriformis, your ITBs, and your glutes medial abductors. I tend to put them on baclofen. Very simple. So you can either use the one of the muscle relaxants like the GABA A, which is the GABA amino butyric acid agonist. So your Valium, we tend to use it all the time. But Valium works on type A receptor, which is predominantly located in the brain. That's why Valium actually makes you more drowsy, compared to baclofen, which works on type B receptor. That's very much located in the spinal canal. So what the baclofen does, it actually goes into your intramuscular gamma neurons, gamma motor neurons, and it actually sort of facilitates it. By doing that, it actually reduces the intrinsic tone of the muscle by itself. That's the mechanism of action. These paravertebral spasms and pain that can be minimized with baclofen, and we have done some observational analysis on review appointments of these patients, and they feel that the back pain is a lot better. Having said that, this could be only one of the causes. They could have facet degeneration, they can have degenerative disc disease. That could be multifactorial lower back pain. However, when you say that the patients with the Parkinson's disease, spinal rigidity is one significant problem postural, and all of them can also cause increased acceleration of your spinal degeneration and spinal canal stenosis. But if you are clinically wanting to treat them for muscle rigidity, it's worth looking at using baclofen as an option. Cognitive dysfunction in dementia, quite a significant problem with this patient group. What I usually see is the memory encoding and processing of information, and I see a lot of cognitive apathy. That's another topic on its own for description, apathy. Apathy can be a symptom by itself, or it can be a syndrome by itself. And in these patients, they can have more cognitive apathy in terms of processing the information, problem solving, multitasking, because the automatic engrams, motor engrams in the brain is lost. So, for example, your driving skills, your walking, your reciprocal movement patterns, they're all automatic movement patterns, which you learn when you're young, and they get embedded into your subcortical networks. That's why you don't have to think about your driving. You don't have to think about walking. You don't have to think about anything, because 1/1,000,000th of a second, all these motor cues are in place when you move your hands. But these patients, they've got degeneration of those neurons. So I tend to teach them the ABCD technique. Very simple, and it works for these patients. Attention, breaking down the task, concentration, and avoid distraction. Simple. So they can use their frontal lobe to bypass the brain, the subcortical structures, to be able to walk better. So I see these patients coming up with freezing of gait disorders. So what they see is when they walk, when they see a different surface, they freeze. They just can't process that information. But if you actually ask them, look, close your eyes, mentally rehearse that you're actually taking some big steps and keep walking, do it for 1 minute, or you can tap audio cue guided, and you actually imagine that you're taking some big steps. You'll be surprised. Next time when you see Parkinson's patients, you tell them this, they'll do a lot better, because you're getting them to use their frontal lobe and bypassing the subcortical structures. And it'll work. And of course, breaking down the task, simple. Concentration, focus is very important, because that's one of the cognitive dysfunction they have, and distraction, avoiding noise. I won't go in depth into the dementia side of it and the pharmacological aspects of it. Yeah, this is quite important. I thought I should touch base. Is there any psychiatrist here or probably not? So depression, mood disorder, Parkinson's disease, a lot of study has been done, 20 to 50%. Is all depression, or it's just a neurological, emotional dysregulation? So depression, as a matter of fact, it's a mood disorder, right? So you ask Parkinson's patients, are you feeling sad within yourself? Are you feeling low within yourself? I mean, one of the depression questionnaire, we ask whether you're feeling suicidal or whatever it is, but are you feeling? Patient says no. But they have got a flat affect, bradyphonia. That's a very flat affect. That's apathy syndrome. The problem here is if you put them on antidepressants, what the antidepressants does, they disconnect your limbic system to your frontal lobe. So they will be more bradyphonic, they'll be more disconnected, they will have absolutely no emotions. You see it next time. You can actually go find out about the Parkinson's disease and apathy syndrome. You'll be amazed how misinformed we are all, and we are treating these patients with antidepressants all the time. But it is worth asking, how do you feel within yourself? If the patients are feeling sad, low mood, that's why it is called mood disorder, depression. If they're not feeling low within themselves and they need cue guidance in auditory or visual, then that's more an apathy. And in that case, it is worth considering, as you probably know, going back to the pathology, the noradrenaline pathway in the locus coeruleus is downregulated. So they are going to have a lower noradrenaline in the system. So they're going to have postural hypotension. So what they're going to have is apathy. So what is the best way of managing that, going back to the pathology, is looking at a selective noradrenaline reuptake inhibition, not just a pure SSRI. For example, if you're looking at paroxetine or fluoxetine, especially paroxetine, fluoxetine, they are pure serotonin reuptake inhibitor. If you look at their pharmacokinetics of it, it's excellent for patients for a major depressive episode associated with a low mood and feeling. But if you put paroxetine or fluoxetine for these patients, they will become even more apathetic. Similar to when these patients go and see a psychiatrist, they put them on antipsychotics, finished. They tend to become even more apathetic, and that will aggravate your Parkinson's symptoms. So in these patients, I tend to use venlafaxine, which is the venlafaxine, desvenlafaxine, or any of those noradrenaline reuptake inhibition seems to work a little bit better. I have used amantadine in my clinical experience, seems to work extremely well. Amantadine is one of the earliest drugs which is used for early onset Parkinson's disease for the reason A, it provides a neuroprotective effect, and B, it augments the production of dopamine in your brain. I also use amantadine for chronic pain, especially for myofascial pain. It works very well in clinical experiences. Your pharmacological companies won't tell you that, because because people tend to use pregabalin, gabapentin, a lot of other drugs, fancy drugs have come. Amantadine works very well with the chronic myofascial pain. And along with that, in this patient group, I tend to use it. On the contrary, anxiety disorder seems to be a little bit occurs along with the depression. And that's probably due to the fact that the brainstem areas are involved in the mood and the anxiety regulation and degeneration. Apathy, we talked about it. It occurs in 12 to 16% of the patients in our group, but I think it's more than that in my opinion, which is classically a lack of motivation, interest, and emotion. There is an apathy evaluation scale. How many of you know that? To assess them objectively. Because we all tend to use the depression scale, DAS. And then we talk about a brief pain inventory. So many scales for depression. Do you know that there is an apathy evaluation scale that you can use, which is not depression? This is so classical, and I tend to sort of educate my colleagues that don't misunderstand apathy syndrome to depression, because your treatment really will matter to these patients. Don't make them a vegetable by giving them just antidepressants and antipsychotics. Sexual dysfunction. More than 50% of the patients, significantly in our patient group, especially due to the autonomic degeneration and parasympathetic and denervation issues, erectile dysfunction is very common, especially my patient groups is about 65 to 85. So childbearing is not a major issue, fathering is not an issue, but erectile dysfunction is a significant issue. So I tend to use the sexual health clinic to give them some counseling and other support. This is a very difficult problem to treat, orthostatic hypotension. As I explained the pathology of it before, why the orthostatic hypotension occurs due to the dysregulation in the noradrenaline pathway. But the treatment options I tend to use is very simple: keep them hydrated, avoiding big meals, and then compression stocking seems to work. It's very simple stuff. It's not rocket science. It just avoids the blood pressure to lower down when they get up. And secondly, I tend to use a medication called Florinef, which is a mineralocorticoid medication, which causes fluid retention into your system. Of course, you need to balance it out with the cardiac failure, but you can use it like 0.1 milligrams daily, and then you titrate it as you like. And then you can also use midodrine and other medications, which increases your blood pressure up, which we use it all the time. Again, when I said domperidone, Motilian, that's a peripheral D2 receptor antagonist that blocks the orthostatic hypotension effects. It's brilliant. Motilian that you're using for a gastroesophageal dysfunction will also help with your postural hypotension as a side effect. That's what we're using for benefits. So much of benefits in using this therapy here. I particularly don't use physiostigmine, but my neurology colleagues do recommend that, but I don't use it in my clinic. So that's the OH. Let's go to the sleep disorders issue. So these patients don't sleep very well due to the degeneration of the regulators of the sleep-wake cycle with the reticular activating system. Again, you can use Ritalin, caffeine, modafinil. This is theory, but with the REM sleep, I think we are at a loss to manage these patients because nothing works. Really, we need to look at the medication which harms them, and you can minimize, for example, noradrenaline reuptake inhibition. You can use modafinil for fatigue management, but I must admit, look, I have not been successful in managing these patients. You can sort of educate on sleep hygiene techniques, but clonazepam has been used. I'm not and melatonin. Melatonin is, again, you all probably know melatonin by now. It's very widely used all over the place. I don't use clonazepam. Now that the current trend is using a very low dose of quetiapine, which is an atypical antipsychotic medication at a dose of 12.5 milligrams, which helps with their hallucinations and delusions. And it also has got the most sedative effect. So I have used it on, but I particularly don't like the antipsychotics for these patients because that makes the Parkinson symptoms worse. You can also have periodic limb movement disorder associated with it. Periodic limb movement disorder. Is anyone aware of that disorder or has heard about it in this group? Yeah. So periodic limb movement disorder, sometimes it's associated with restless leg syndrome. Now, this is a huge topic. I'll just quickly touch base why it is important. Because the periodic limb movement disorder causes cortical augmentation of the dopaminergic system, which means, and the pain, and if you put them on a medication, it'll make the symptoms worse. It is very difficult. And the only medication that seems to sort of vaguely sort of helps them, would you believe, which is, it's an open secret, is opioids. So we don't want to push that part because we can use the periodic limb movement disorder with OxyContin or MS-Contin, but you can't give them dopamine. You cannot give them dopamine, because the moment you put them on dopamine agonistic medications, it causes cortical augmentation. It's a different network, because with the dopamine, we have D1, D2, D3, and D4. In this case, it's more D3, D4. So if you look at it, so the D1, D2 becomes more upregulated. So it causes cortical augmentation that becomes worse. So the open secret is, yes, a small dose of opioids, but we won't talk about it much. And that completes my non-motor symptoms. My practical experience, we've rolled out this clinic in middle of 2022 as a new model, novel model of care in Australia. But ours is the only clinic in Australia to talk about the filter in and filter out model. We're not competing with the movement disorder clinics with the neurologist. So it's actually complementing with the neurologist so that patients can access our management guidelines of the NMS symptoms. And we provide an integrated discharge summary package to the GPs. So GP can contact me anytime if they want to tweak the medications. I'm happy to do that. Neurologists are quite happy with that. So it's an overall good outcome for the district and as well as the patients. And that concludes my talk. Thank you so much.